Good afternoon, or good morning, depending on where you are. Welcome to today's webinar entitled Quality Reporting, Measuring Outcomes, Reporting Data, and the Mental and Behavioral Health Registry. This webinar is hosted by the APA Practice Organization. My name is Nicole Owings-Bonner, and I'm a Communications Project Manager in the Practice Directorate at APA. I will be moderating today's webinar. The webinar is being recorded. A copy will be emailed within 72 hours to all participants and those who registered but could not join the live presentation. A copy of the slides used during today's presentation can be found in the handout section of your GoToWebinar panel. There will be an opportunity for question and answer during this webinar, including a sample of those previously submitted questions that you entered during registration. Please use your questions box to submit questions at any time during the presentation. Our presenters today are Ms. Diane Padula and Dr. Vale Wright. Today, our presenters are going to discuss with you and help you understand the following objectives: to understand CMS's proposed rule changes to the Medicare Access and CHIP Reauthorization Act and the Merit-Based Incentive Payment System, otherwise known as MIPS. We're going to learn about the development and benefits of the Mental and Behavioral Health Registry, and you're going to receive answers to your questions about federal regulations and quality outcome reporting from the experts. To begin, I'm going to turn things over to Diane.
Thank you, Nicole. Well, this truly is welcome to MIPS for psychologists. 2019 will be the first year that psychologists will be considered eligible clinicians for purposes of this new reporting program. Next slide, please. CMS on July 12th issued what is known as the proposed rule on the 2019 Medicare fee schedule. This is the vehicle that the agency uses every year to alert healthcare providers and the public to its proposed changes for the coming calendar year. Of great interest to psychologists this time around will be some very important changes for testing services and for psychologists' introduction to the merit-based incentive payment system. We are not going to be talking about testing services today, but there will be additional information available on the APA and APA Practice websites. Comments for the proposed rule are due September 10th, 2018. Anyone is invited to make comments if they choose to. APA, of course, will be making a formal comment on behalf of all psychologists. This rule will be finalized in early November. Whatever goes into the final rule in November will be what psychologists and others will need to follow come January 2019. So what's so important about the Medicare fee schedule and the changes for 2019? Some of this we have really been talking to you about for quite a while now. We were well aware that psychologists were not going to be included in MIPS when it first started in 2017, and that the earliest possible time when CMS could add psychologists, along with a number of other non-physician providers such as licensed clinical social workers, PTs, and OTs, was going to be in 2019. What's happening is that the definition of a MIPS-eligible clinician, meaning those providers who are able to report MIPS measures and potentially earn bonus money through this program, have to be included in that definition. This does not happen immediately. Very similar, for those of you who remember the previous Physician Quality Reporting System, or PQRS, your reporting is done in a particular year, but it does not impact your Medicare payments for another 2 years. So any psychologists who are reporting under MIPS in 2019 will not see an adjustment to their Medicare payments until 2021. For 2018 and 2019 and 2020, there is no quality, for 2019 and 2020, there is no quality impact upon your payments. For anyone who did not successfully report under PQRS in 2016, you are already seeing adjustments to your 2018 payments. So how much is at stake here? Well, it's fairly significant by this time. Keep in mind, MIPS has already been in place for 2 years now, while physicians and a number of other allied healthcare providers were able to report under this program. So while it initially started out at a slower gradation, we have now reached the point for the 2019 reporting period where the potential adjustment in 2021 will be as high as plus or minus 7%. That may sound a bit daunting. It's very, very important to keep in mind that this system was really designed with the expectation that most providers are going to be considered average. And by average, what that means to CMS is you're doing just fine. Your payments stay exactly the way they should be under the current value system. And only those that for some reason are below par or are showing exceptional quality performance would be adjusted either up or down 7%. So does this mean you have to report in 2019? Maybe not. In fact, we're predicting that many, if not most, psychologists will not have to report under MIPS if they choose not to. And here's why. There is something built into MIPS known as the low volume threshold exemption. It was designed to ease the burden on solo and small practices that typically have relatively few Medicare patients. These systems tend to work best when a provider has a significant number of patients and provides a variety of services. So obviously that works against a solo practitioner who sees relatively few Medicare patients. So here's the criteria for what we refer to as the LVT exemption. Billings of $90,000 or less in Medicare allowed charges, 200 or fewer Medicare patients. New for 2019, technically it's just proposed at this point, but what CMS would also like to add is 200 or fewer covered Part B services. You only have to meet one of these three criteria to be exempt from MIPS. I also want to add that any clinician, regardless of their specialty, if it is their very first year as a Medicare provider, if it is the first year you have enrolled in Medicare, you are automatically exempt from MIPS reporting. It does not matter whether you fall under this criteria. Just the fact that you are a first-year provider of Medicare will automatically make you exempt from MIPS. So how can you be certain whether or not you will meet the criteria for an exemption? Well, many of you will know very easily if you have relatively few Medicare patients or can look back at the amount that you billed Medicare for last year. But the way Medicare officially makes this determination is it will review claims data for providers going back to October 2017 and continuing all the way through September 2018. After it has reviewed this information, it will actually notify eligible clinicians by mail whether or not they are exempt from MIPS. Now, something else that's going to be new in 2019, just showing up in this year's proposed rule, is the idea of allowing providers to opt into MIPS even if they would be exempt under the LVT criteria. And it's very, very important to understand this is optional, and there's two pieces to it. You still have to meet at least one of those three criteria. If you see fewer than 200 Medicare beneficiaries, if you provide fewer than 200 Medicare services, and if you bill for less than $90,000, then you are out no matter what. You do not even have the option of trying to get in. But if you meet one criteria but not the others, then you would have the option of reporting under MIPS if you decided that's what you wanted to do. The most important thing to keep in mind if you fall in that category is once you make the decision to opt in, you are committed to it for that performance period. So you can't opt in and start reporting in early 2019 and then halfway through the year decide, no, I don't like this, this is too much trouble for me. I originally could have been exempt, so I want to go back and say I'm exempt. It would be too late. You would be committed for the 2019 performance period. Something else that's going to be new in 2019 that might also be of interest to some psychologists, and that is the concept of forming a virtual group. Again, CMS recognizes that solo practitioners and small practices have a much more challenging time trying to successfully compete under MIPS. So there is the opportunity for solo practitioners and groups of 10 or less to form a virtual group, aggregate all of their reporting data. Now, and a very important thing to keep in mind, for a solo practitioner, you still must meet the LVT criteria. So if you as a solo practitioner would be exempt under MIPS, then unfortunately you do not have the option of forming a virtual group. But if you, for example, were part of a group that shared the same TIN and others in the group were eligible for MIPS, then it would be possible for your small group of, say, 5 to form together with other groups in order to have a larger patient population and more data to use for MIPS purposes. I want to emphasize again, this is still in the proposed stage, so it is possible that CMS could make some changes to what they are proposing at this point. We will not know for certain until the final rule is released in November. If a virtual group is formed, there will have to be some structure to it. There has to be a formal written agreement among all members in the group, and CMS already has some sample language available on the website if people are interested in this. They also have to name an official representative, and the representative of the group is the one that has the responsibility for making sure that the group actually makes an election to CMS, and there is a specific time period for that, and it has to be done by December of the year prior to the performance period. So you cannot wait until the performance year starts and then decide you want to form a virtual group. One of the things that is attractive about virtual groups is there's really very little in terms of limitations or restrictions on who and how you can form one. So you could form one of all psychologists. You could form one of all psychologists in a given geographic area, or you could form one with people in very distant geographic areas. There's no restrictions in terms of categories like that. So if you do have to consider MIPS, or if you have the opportunity to opt into MIPS and decide that's what you would like to do, I'd like to give you a quick overview of the different performance categories that you would be reporting under. Quality, again, very similar to what many of you may remember under PQRS, although fortunately the requirements are less burdensome this time around. If you remember, PQRS had gone all the way up to 9 measures by the end, and many psychologists were really struggling to find 9 measures that fit their practice. This number is now down to 6, so it's much more workable. There is something known as clinical improvement activities, very, very good examples of certain ones that would fit the practice for a psychologist. There actually is a behavioral and mental health set. I'll be talking a little bit more about that afterwards. Something known as promoting interoperability. This is really the old meaningful use for electronic health records category that existed before MIPS. The good news, psychologists are not required to report in that category. Cost is one of the performance categories. There is no actual reporting required on your part because CMS takes the data that it needs directly from the claims that you filed. A bit more of a breakdown on each one of these performance categories. As I said, for quality performance, you will be reporting 6 measures. That is over a 12-month period. There are bonus points for small practices of 15 or less, assuming that they would even be in MIPS to begin with. And to give an example of some of the behavioral and mental health measures that currently exist for MIPS, there's adult major depressive disorder, the suicide risk assessment, dementia screening and management. There really are quite a number of dementia measures that are available to you because under PQRS there was actually a dementia measures group. The group was disbanded, and now all of the dementia measures are available for individual reporting. The elder maltreatment screen, depression screening, and also screening and treatment for alcohol use and tobacco use. Next slide, please. Okay. The improving clinical practice activities. Requirements are a bit different from this one. You only have to report for a 90-day period, so you could identify a particular time of the year that you wanted to report this particular category. It's done a bit differently. You actually can go onto the CMS website and simply attest that you have been performing these particular activities. To give you an example of some of the behavioral and mental health measures for this category you're talking about, it's going to sound very similar to the quality measures, but they are set up a bit differently. There is depression screening, there is integrated behavioral health, there is major depressive disorder prevention and treatment, alcohol use, and tobacco use, and a number of others that are really related to the way that people organize their practices and do things that make them more patient-friendly, such as the hours that they're available or the telephone and messaging systems that they use. Promoting interoperability. Okay. If any of you paid any attention to MIPS over the last couple years or some of the things that we were writing about MIPS, you're more familiar with this as the Advancing Care Information category. It's the same thing, it's just under a new name. And this is the part that refers to the certified electronic health record technology that physicians and some other healthcare providers have to report on at this point. Psychologists and the other non-physicians who were not part of meaningful use, who never had the opportunity to receive financial incentives to invest in these types of systems, are not required to report in this category. So what happens if you don't report? Well, fortunately, CMS will just automatically reweight this category to 0. They will add higher percentages for quality measures and for the clinical improvement activity measures. For those of you, if you choose to report under this category, say you are part of a practice that has invested in electronic health record technology and you feel that there are applicable measures for you, you are welcome to do that. If you do, you can pick a 90-day period if you want to, rather than having to report for the entire year. Okay. There are a variety of ways to report under MIPS. Claims reporting is still available, but it is very, very limited. It can only be used for the quality measures. It can only be used by small practices of 15 or fewer. And I really, really want to emphasize, even though we have not been actively part of MIPS for the past couple of years, seeing what has happened with other specialties, claims, the same way it was under PQRS, has the highest error rate. So there are other ways to do this. I highly, highly encourage you to explore the other ways where at least your chance of success is much higher. There are some areas where you can simply go online and upload your data. As I mentioned before, with the improving clinical practice activities, you can go online and simply attest for those particular measures. You can also report directly through EHRs if you have that type of a system. And you can report through what is known as a qualified clinical data registry. And that is much of what the rest of this webinar is going to be about, is helping you understand the value of a registry, and in particular, the one that we have created, the Mental and Behavioral Health Registry. So why should you care if you don't even bill Medicare? I'm going to turn this over to Dr. Vail Wright to explain that to you.
Thanks, Diane, and I want to thank everybody for attending this webinar today. I'm real excited to talk about this topic and how APA is working to address it. The answer to this question is, if I don't bill for Medicare, why should I care? Or if I fall under the low volume threshold, why does this matter? And as Diane said, for some, it probably won't. But I think it's really important that people think about that given its role as the largest health insurance provider in the country. The U.S. federal government is spearheading the implementation of such payment reforms through these regulatory and legislative changes. And so it's important for psychologists that realize that value-based payment initiatives related to behavioral and mental health could impact your practice, as the federal government is often the driver of change that then trickles down to third-party and commercial payers. So while this might not affect you now, we really do think that a quality improvement is here to stay. It's not going away. So it's important to be both knowledgeable about these changes, but we also really wanted to make sure that psychologists have access to resources to effectively participate as the healthcare world changes. So if we go to the next slide, it'll give you an overview of sort of what I'm going to touch on today, which is really just introducing the initiative that we started here at APA, and we're going to go over some definitions. We're going to talk about the advisory committee that's really spearheading the measure development and the prioritization of the project. We're going to talk a little bit of what we see are the benefits of participating in a registry. We're going to have a video demonstration, so I really hope everyone can stick around for that, because I think it really gives you a flavor or a sense of what the platform is. And then finally, we'll end on pricing, which is, of course, the most fun part. So if we go to the next slide, I'll talk a little bit about kind of what a data registry is. I mean, this is a term. Registries in themselves have been around for a long time, but it's not something we typically talk about in psychology. It's not the lingo that we have, but really what a registry is, and you can read the bullet points there. The way I think about it is it's in essence, it's an outcomes database, and that is something that we're familiar with. Now, what differentiates a qualified clinical data registry is that it's a CMS approved entity, or a CMS approved outcome database. And so it requires going through a rigorous review done by CMS to ensure that what you're providing to your members and to others is a quality product or platform. And the reality is that CMS is really encouraging specialty societies such as ourselves to develop our own QCDRs in order to report to MIPS. And part of the reason for that is some of the challenges that, again, Diane just alluded to under PQRS, which was that there was a real lack of measures that were relevant to psychologists and other mental and behavioral health providers. And CMS knew that. And so instead of trying to please every specialty out there, they instead reached out to the specialties and said, why don't you develop the measures yourselves, because you are the experts. And so that's really what we've been trying to do. And so I'm cognizant of time, and I'm not going to go through the whole background of how we got to where we are, but I want to ensure people that we've really have trying to take a strategic approach to identify what are the resources that psychologists need to be able to adapt to the changing healthcare environment. And so in that vein, we have partnered with HealthMonix. We've been a partner with them since 2014. And then in the interim, we convened an expert work group, and in collaboration with APA Governance, decided to move forward with a self-nomination to CMS. And so in December of 2018, CMS did approve our mental and behavioral health registry to participate in MIPS for 2018, and we'll follow the same process again for 2019 to ensure, again, that there is a resource for psychologists who want to participate in MIPS. And as I already alluded to a bit, our measure development is really being guided by the advisory committee, which is a group of experts from across the country with a variety of different expertise in either outcomes management in a variety of different areas. We went through a call for nominations process to arrive at our CAP-approved committee of experts. It's chaired by Dr. Carol Goodhart. For those who aren't familiar, she's a former APA president. She works in private practice, and she reported to PQRS under the old system, so she's incredibly familiar with how this works. And if you're interested in learning more about our experts on this committee, you can find their bios on our website. So let's touch briefly a bit on what we sort of see as some of the benefits of an APA-branded registry for MIPS. All the regulatory reporting requirements really served as the catalyst for developing the registry. The initiative is really intended to have a much broader focus. So in addition to collecting patient-reported outcomes that can be used by therapists and patients to improve care or to report to MIPS, we really see this as positioning psychology and psychologists as leaders. It allows us to define, develop, and select the measures that are the most interest and importance. And I think as a discipline, it allows us to be the ones who define what is quality mental and behavioral health care, as opposed to letting either other organizations or the federal government or other entities to define what quality is. That it is our responsibility to be the ones to bring our expertise to this and really define what quality looks like. We also see it as an avenue for improved reimbursement, not just in terms of those who are going to report to MIPS, but also with negotiating with commercial payment programs that have value-based programs that are out there. We hear from insurance companies that they are also moving in this direction. They don't know how to differentiate the providers on their panels, and this is one of the ways that I think we can work with insurance companies to improve your reimbursement by saying, look, I'm collecting outcomes. Here's how I look compared to others, and that's why you should be paying me more. In addition, as I've already alluded to, there's the quality improvement or tracking client outcomes component of it. There's a real-time dashboard, so you can see how your patients are doing. There are benchmarking opportunities, so you can look at how you're performing relative to other providers who may be seeing similar clientele. So again, that you can use that information both to know where you might need to improve the work or how your clients are doing, but also to be able to know how you're doing relative to your peers. And this leads into the next benefit, which is really, again, trying to anticipate where we see healthcare moving to. We have talked with ABEP, for example, and we know that they are moving towards a maintenance of competence model, and so these are the type of data that could be used to maintain that. We hope to offer additional continuing education opportunities through the registry, again, to help individuals shore up any areas of quality that they might need to. We think that there's also a marketing aspect to this, where you would be able to demonstrate the value add of psychology and of having the doctorate, because I think that psychologists are going to be able to say, look, I collect data, I know that what I'm doing is working, and that's why you should pay me. Finally, over time, we anticipate that there will be a clinical research aspect to this as well. Many other societies have used their data registries as a way to conduct research. For example, there's a data registry in skin cancer, and what they found was that individuals who are married were more likely to be diagnosed and then to receive adequate treatment for skin cancer. And that's just sort of the kind of research you couldn't get out of an RCT. So this really provides what we see as the largest naturalistic psychotherapy outcomes database, and the advisory is working on how would we maybe make de-identified, obviously, data available to members in the clinical science community. So what is it? What are the nuts and bolts? So as you'll see in the demo, what the MBHR is, it's a cloud-based, HIPAA-compliant platform. There are multiple ways that you can enter data, either from your own certified EHR, you can upload an Excel spreadsheet, or you can manually enter your data into the dashboard itself. We currently have 28 what are called MIPS measures, so these are the CMS stewarded measures typically. And Diane already included some of those examples, including the suicide risk assessment. We've added some new ones, including a functional outcome assessment. So if you give a functional outcome measure, such as the PROMIS or a quality of life measure, you can receive credit for doing that. And then on the next slide, one of the things that is exciting, I think, about the MBHR is that because we're a qualified clinical data registry, we can create new measures. And so our advisory committee during their in-person meeting last year identified that one of the largest gaps in the measurement field is the lack of anxiety measures, that there were literally 0 anxiety measures available from CMS to use in MIPS or PQRS in the past. So what the group did was they, using the GAD-7, developed 2 new measures that are only available in our registry. And those are, again, if you give a GAD-7, say to screen for depression, to screen for anxiety, you would get credit for that under MIPS. Or if you track anxiety over time by giving the GAD, 2-3 times, you could also receive credit for that. And that outcome measure has a high priority as well under MIPS. So these really, I think, are some exciting things that are unique to our registry. And moving forward, the committee really is looking at more transdiagnostic measures, such as looking at functional outcomes, looking at quality of life, sleep, pain, these sorts of things that are not necessarily symptom-based, but could be used for a wide variety of individuals, and where you might see more of the improvement that both you and your patients actually care about. Okay, so now we're going to shift real quick, and we're going to have, it's just a 3.5-minute video. It was created by Dr. Carol Goodhart, as I mentioned before. She is the chair of advisory committee. She currently works in private practice. She's the former APA president, and she created this demonstration that we showed at convention, and she's allowed me to show it here to all you today. So I know that Nicole's bringing it up as I talk, and I'm just going to allow her to play it for us when she's ready. Or you can look at our pictures.
Once your purchase is complete, you will be able to access the dashboard. These are the MIPS Pro components and their scores. You won't use all of them, some may not be relevant to you. Click on Profile on the left. The tabs across the top are the profile pages to be completed as applicable to you. For number 3, email preference, click on Practice Admin or Provider, or both if you serve in both roles for your practice. Now click on your name, upper left, to return to the dashboard. Click on Quality, click on Measures, and on My Measures. Search for the measures you want and select them. A minimum of 6 is required. When you are finished, return to the Quality Checklist and complete the electronic reporting items and the mandated measures items. Then you may return to the Quality Checklist and go to the next tab, Data Entry. Enter your data manually or click on Data Integration to upload your patients and visits in spreadsheets. The majority of current users use Excel to upload their data. The site provides you with a link to download the spreadsheet templates for visits and for patients. After entering the data, click Quality Performance in the upper right corner. There you will see your results. Click on the Decile tab on the right to see your performance compared to Medicare's benchmarks. Click on the Quality Points tab to see your top performing measures. This is your feedback on the measures that you use. Click on the CMS Performance tab, then click on any number you like to see your patient visits page. For this test account, the patient column doesn't list patients. It says provider 2, 3, 4, etc., but yours will show your patient identifier. Most providers use the patient's name, but you can pick any identifier that you will remember because you'll have to use it again. Click on the green or yellow circles to see any particular date of service detail. And this will be your feedback for that particular visit's date of service.
Thanks, Nicole. So that just sort of gives a little bit of a taste of what the platform itself looks like, how you would enter data, and how it might be useful to you in your practice. And so now we'll talk a little bit about what the pricing options are for both members and non-members. And what you see here is we have a tiered pricing structure based on a couple different things. One, again, if you're a member or not, but also what type of reporting level you might use under MIPS. So if you're an individual or a group who either plans to or hopes to report to MIPS, it's likely that you would fall under the sort of standard tier. That would allow you to report both quality and also the improvement activities. The plus includes whether you have a certified EHR. Again, as Diane said, most individuals do not, but that's when you would fall under the plus category. You can see that the APA member price is less than the non-member price. The reality is this is the lowest price point that we could work out with HealthMonix. Under the APA member price, APA receives no revenue from this. This is not an attempt for us to make money off of our membership. This is an attempt to provide a resource so that psychologists and others who use the registry can be effective and successful in these sorts of value-based reporting programs. Because as you saw under Diane's slides, there's a lot of components to this. It's very complicated and claims are not likely to be effective going forward. On the next slide, you'll see that in addition to having an option for those who want to report to MIPS, we also envision, as I mentioned earlier, that the registry could be used more broadly than that. So even if you're not a MIPS provider, you don't report to Medicare, you're going to fall in the low volume threshold, but you think that you might be able to use this resource in your personal practice. So you're tracking individuals in your practice and you're either using that data to negotiate with commercial payers or as a quality improvement initiative for your practice, but you're not intending to report it to MIPS. This is the fee schedule that we have available. So again, you can see that the APA member price is significantly less than the non-APA member price. And these are prices for the year, not monthly. These are yearly prices. And I think with that, I think my section's done.
Thank you, Diane and Vale, for all of that information. At this point, we're going to go ahead and move into our question and answer portion. First, I want to thank all of those who submitted questions prior to the webinar. We hope that the presentation so far has covered many of them. I will now be asking the presenters several specific questions that may have not been fully addressed yet, as well as some that we've received during the webinar. So to start off, how will this apply to a practitioner who works solely with children?
Yeah, thanks, Nicole. I think I'll start with that one. So at this point in time, all our measures are currently for adults. However, we have received a lot of feedback from individuals that they really want measures related to children and adolescents. That information has been reported back to the advisory committee, and it's one of their major priorities for next year in terms of including measures that would be applicable for both children and adolescents.
Thank you. Can you discuss the legalities, especially surrounding patient-informed consent, of storing patient information on the MBHR? Who has access to the data? Is it kept confidential?
Yeah, and maybe Diane can hop in on this one too. But so as I mentioned earlier, it's a HIPAA-compliant platform that only you or your designee would have access to. Now that changes obviously if you submit it to CMS, and CMS has access to the data as well. There is a business agreement that you sign with HealthMonix that covers, again, these HIPAA situations and the confidentiality of the data. You have, as it said in the video, you have your own determination of how you want to even enter your data. So you could de-identify all your data by just giving numbers to your individuals. So even in that platform, nobody would have access to the names. Although, like I mentioned before, it is HIPAA compliant, and Healthmonics as a vendor has to maintain an agreement with CMS that they will keep the data secure. Diane, do you have anything to add to that?
No, I really don't.
Okay, then we'll move on to the next question. What's the difference between this and Healthmonics?
Right, so this is another question that we've seen a lot. So Healthmonics is the vendor, and we've been working with them since 2014 to provide, again, a cloud-based platform for individuals to be able to submit their data to CMS. Originally, that registry was specific to PQRS, and that registry has shifted over time as we've expanded what we wanted the registry to do and to be able to report to MIPS. So Healthmonics is the vendor. They are still who we are working with, but we as APA and APAPO are the stewards or the owners of the registry itself. So hopefully that clears some of that up.
Yes, thank you. A few people had questions about the low volume threshold. Is that low volume threshold for an individual provider? How does it work if you're in an integrated medical clinic or hospital setting? Is it based on the clinic's numbers or just the individual psychologist's numbers?
It is typically based on the individual psychologist numbers. So, for example, if you're part of a group or a clinic, you could have people within the group that would be exempt from MIPS because they individually don't see that many Medicare beneficiaries, while you could have another person within the group that would either be required to report under MIPS or at least have the option of reporting under MIPS, depending upon where they fall under the criteria.
Okay, thank you. Multiple people have asked which specific electronic health records work to upload directly. Is there a list available somewhere?
Yeah, thanks. So there is a list available on the Healthmonics website. I know, for example, Epic is one. I believe there's a second one as well. My apologies for not looking at that ahead of time. And I know that they are in communication with other EHRs or other programs that psychologists are likely to use to create relationships. Oftentimes, even if you have a specific EHR that you're working with and they haven't worked with yet, that they can get creative in terms of how they do their APIs so that the two can talk to each other. So that would be, if someone's interested, something that Healthmonics could help address.
Okay, thank you. Do you have a comprehensive list of the measures currently included in the MBHR? And a follow-up, are users able to add additional measures that meet their own needs, some that they may already be utilizing?
That's a great question. So there is a list of the measures on our website. I believe you can also access it on the Healthmonics website as well. They have a measures tab. And at this time, no, there wouldn't be necessarily a way to add your own measures into the registry. I think it's an interesting idea. Part of what we have to do in order to maintain our qualified clinical data registry status is that we have to vet our measures through CMS. And so that requires what's called a measure specification. And in a measure specification, it's a little bit different than just having, say, a scale like the BDI that you give to, your patient caseload. What it requires is to turn that scale or that measure into a performance metric. And what that looks like is having to specify a numerator and a denominator, as well as exclusion, so that you can come up with a score, a performance score. And so it's a little bit more involved, and again, it has to be vetted by CMS. But I'll certainly take that question back to the committee and think about, are there ways that we can create a platform that is more adaptable to individuals who maybe aren't submitting their data to CMS.
Thank you. An additional question, that just came in is, are there elements of this that would be useful to neuropsychologists providing assessment services?
Yeah, I believe so, and Diane might want to jump in on this one too. So we've been talking with neuropsychologists about how the registry might work best for them. Then there's a couple different ways. One is the dementia measures that Diane spoke about earlier. Those are often very popular with neuropsychologists. There are also some additional measures related to assessment or sort of referrals. So for example, one of the new measures that CMS has introduced is something called closing the referral loop. And I think that that would be something that could be very useful to neuropsychologists, because you would, in essence, get credit for when you get referred somebody for testing, you complete the testing, and then you submit, your report, or you follow back up with whoever the specialist, that the individual that referred them. That is a MIPS measure, and you would be able to get credit for that. So I think there are some things that are already in place. It's certainly on our radar to continue to figure out ways that we can make this the most relevant to neuropsychologists as we can.
Thank
And
you.
Dale, I would just add, I think that was an excellent example for you to provide, given that many neuropsychologists are often working very closely with physicians, depending upon the condition of the patient. So something like closing the referral loop would be something that would probably be very, very useful to them, in addition to, as you mentioned, the dementia measures, which heavily emphasize assessment.
Thank you. And I have two questions that I believe are for Diane. Could you, for the low value threshold, is the 90K threshold in what CMS pays or what you bill CMS? So your rate might be one thing, but what they pay is a different amount.
Right. It is for what you bill CMS for.
Okay. Thank you. And then could you please clarify the process by which payments are adjusted based on reporting?
That it's very, very complicated made when you refer to the different categories, and I unfortunately we'd need way more time for us to try to explain it at this point. But essentially what would happen is they are looking for indicators of either exceptional performance or underperformance. And what then happens if they find that, and again, the expectation is the majority of the providers are going to be just fine and there would be no adjustment at all. But if they do find somebody is underperforming or overperforming, then what happens is 2 years later, you have an adjustment to, and this is a slight change from the past, Medicare wants it to be an adjustment to your Medicare Part B payments. This isn't as big an issue for psychologists as it is for some other providers, but in the past, they were applying it to all Medicare payments, whether they were Part B or Part A or whatever. But for psychologists, I think the vast majority would be Part B anyway. There is still some, I don't want to say confusion, but I think question marks in terms of exactly how CMS is going to make these determinations for the non-physician providers like psychologists and social workers. And the reason I say that is because all the examples that they provided us with when MIPS first started in 2017 seem to take into consideration comparing practitioners on the basis of their use of E&M codes. Well, we don't use E&M codes, so that is not an option. So the most likely replacement for that would be, do you look at the performance under codes psychologists do use? So for example, are you looking at psychotherapy services? Are you looking at psychotherapy services just between psychologists? Are you looking at psychotherapy services between psychologists and social workers and potentially psychiatrists? That is part of the area that we still have a question mark. We haven't had specific answers from CMS as to just how this is going to be applied for the non-physician providers coming up.
Well, thank you for attempting to explain that for all of us. I have another detailed question. For the third LVT exemption, does it not automatically rule out most all psychologists as there are not enough CPT codes the covered Part B services that are typically used by psychologists?
Again, I'm struggling to think of what psychologists would be billing Medicare for that would not be a covered service. It's a little bit different again on the physician side. For example, I think there was one example that referred to medications and some other things that they may be involved with. It's really hard for me to think of something that a psychologist would be billing Medicare for that would not be a covered service. So I'm not really sure adding that third category is going to make any difference for purposes of psychologists. I think in most cases it's just going to be, how many patients do they have?
Thank you.
Diane, can I follow up on that? Because I have a question about that too.
Yes, you can. Sure.
But you could have one patient where you bill more than one service. Isn't that correct?
Certainly. Yes, certainly.
So, I mean, I think that's how that one could be more relevant in that, let's say you have 100 patients, but you've billed 2 services or 3 services for each, and that would pump you out of the low volume threshold, correct?
Yes, assuming you were still, if you were not out under either of the other 2 criteria.
Mm-hmm. Okay.
So if you have 100 Medicare beneficiaries and that's all you see in the course of the year, then it does not matter how many services you provide to them. You're still going to meet one of the 3 criteria for the number of Medicare beneficiaries that you treat, and that alone is enough to get you out. Now, the flip side of that is, to take your example, Vail, if you provide enough different services to those 100 Medicare beneficiaries that you cross over 200, now you're in the land of you can opt in if you want to. So it won't alone force you to be in, but it could allow you to have the option to be in.
Right. Okay. Yeah, that's kind of what I was getting at. Thanks. I appreciate the clarification.
And
Thank you.
excuse me, because I'm so accustomed to people asking me from the perspective of how do I make sure I'm out.
But like you mentioned, I think there could be benefits that for certain individuals to want to participate in MIPS, given, I think that psychologists do provide a high quality of care, and I think that they could potentially see those increases in reimbursement.
Definitely.
And I just want to clarify, because I've gotten a few more questions. I think that some people were concerned that the covered Part B services at 200 seems like a very low threshold, given that one psychologist explained that they would exceed the threshold if they saw just 4 Medicare patients per week for 48 weeks. But it sounds like you're saying that they just need to hit one of those exemptions.
Exactly.
Okay.
Just
Thank
one,
you.
and that's enough for you to be out.
Thank you. I have another question. These are great questions. Please keep them coming. How is a group defined? By NPI or tax ID?
Everybody still retains, CMS still looks at each individual NPI, so a group is a collection that is billing all under the same tax identification number.
So to follow up with that then, if the services are delivered by a number of different clinicians, are they required to report through a registry, or can they still use claims-based reporting?
The claims-based reporting, again, is only available for one of the 4 categories. So they potentially could report the quality measures through claims, but they would have to use other ways to report on the other categories that they were interested in. So short answer, no, they would not absolutely positively be forced to use a registry, but they may find it easier than trying to put together several different pieces of ways of reporting.
Okay, great. I have another question regarding the registry. Are there pricing options for multiple or group practice users?
So the way that it works right now is that each one is an individual license. So no, each person of the group would have to purchase their own license. But if people have feedback on that or things that they want us to consider, certainly we're open to it and can think about how we might, renegotiate a contract in the future.
Okay, and I have one last question as we're starting to hit our 1 hour mark. The MBHR benchmarking ability that was mentioned, can you use this benchmark against other providers outside of your practice? What information will people be able to see in terms of comparison?
So basically, the benchmark is based on how much data you have on a measure that gets reported to CMS. So basically what you would be able to see is how you compare to everybody else that has reported on that measure to CMS. So you wouldn't see who those individuals are necessarily, but what you would be able to say is compared to everybody else who gave the PHQ-9 screening measure, I performed in the 90th percentile or the 80th percentile compared to everybody else. So you were more, for all of the patients that you had with a depression diagnosis under a particular CPT code that you billed, you could say, I screened, 100% of the time compared to everybody else. I hope that's helpful.
Yes. Well, I want to thank our presenters today for all of that information. And I want to kind of close by pointing out some additional resources on this topic. If you click on the variety of links there on your screen, and then on your handouts, which you'll be able to find the actual links, we have information all about the mental and behavioral health registry, what clinical data registries are and different tools, how to evaluate them, and a variety of different things for information. I would also encourage you to check out the APA Practice Central website. And if you happen to have questions regarding Medicare or MIPS, you can contact Diane directly. Her email is dpadula@apa.org. To check out the MBHR registry, we've provided the link there. And if you have additional information regarding the registry that wasn't covered today, please feel free to contact Vail. Her email is cwright@apa.org. Additionally, if you enjoy our webinars, I would encourage you to check out Progress Notes. It is a podcast produced by the APA Practice Organization with practicing psychologists in mind. Just like our webinars, they cover a variety of topics that affect practitioners. And just recently, I believe today, the new installment of Progress Notes will be airing that covers specifically the MBHR. So if you want some different perspectives or more information about it, our newest Progress Notes is out at that link. And I just want to thank you for attending today's webinar. As we said at the beginning, a link to today's recorded webinar will be emailed to all registrants within 72 hours. In addition, the slides and the recording will be available on the APA Practice Organization website in a few weeks. We'd love to get your feedback on the webinar. When we send around the recording email, there would be a link to a survey. Please feel free to fill that out and share whatever thoughts you'd like us to have. Thank you and have a great day.